on this episode of A Tale of Two Hygienists.
Mouth breathing isn't really ideal for any human. Nasal breathing is by far the healthiest way to breathe. Of course, we know that it's not really possible for all people. Maybe it's, a deviated septum or some other kind of condition. But ideally, everybody would be nasal breathing as much as possible. I think at the very bare minimum, the easiest way in is to use, a clinically validated questionnaire. The Epworth Sleepiness Scale, for example, that's something that you're always going to need. And that's something that you can just add into your intake forms. And maybe you only know the basics. Maybe you just know the scoring, and that's what you go over with your patients. Maybe you just look at their anatomy, and that's what you go over with the patients. But I think that all of that is something that the hygienist can do. Oral appliance therapy used to only be for mild sleep apnea. Now it's for mild or moderate sleep apnea. And even if the patient has severe sleep apnea, oral appliance therapy can still be recommended, and it can still be covered by many insurances.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode 445. My name is Annie, and we have a great show for everyone today. This episode is the first of a two-part series that we recorded with Teresa Power DeNike. She is the founder of Sleep Better NYC, and we had the pleasure of learning about obstructive sleep apnea from her. She also shares with us the dental hygienist's role in screening for this condition, and just actionable steps we can take during the hygiene appointment to get patients the help and support that they need. Then next week, we will hear the part 2 of this series, where Teresa discusses mouth taping and other sleep hacks that can help get you and your patients sleeping and feeling better. There's a lot of studies and information being released about how we breathe, and I think it's really critical that we, as hygienists, are at the forefront of this so that we can provide our patients with the most current information on best practices as they come to us and ask questions. This episode will really do just that, so be sure to come back next week and tune in. In other news, I recently saw that the state of Illinois passed a law that I found was interesting, that social media influencer families that feature their children that are under the age of 16 must pay their child 15% of their gross income within a 30-day period if the child is in at least 30% of a video or online content for which the adult or a parent or caregiver is being paid. And so the person that's making the videos is responsible for setting aside gross earnings in a trust account for the child, and then the child can receive that at age 18. So I thought this was just really interesting, especially in this day and age. We know a lot of influencers and family influencers, so they're trying to set some regulation and boundaries around children. And so Illinois is the first state in the country to have this type of law, but other states like Washington, Maryland, and California are also considering this, really as the influencer industry begins to grow. They use the term sharenting, which I've never heard before, but also family vlogs where families are out on the internet, out on social media, and it's really grown in attention. And so again, this law was just helping to establish more regulation around children. So I thought that was kind of interesting. Anyway, thanks again for listening, everyone, and really enjoy this episode with Teresa Power DeNike.
A tale of two hygienists.
Welcome, everyone, into the interview portion of the podcast. We're joined today by Teresa. Teresa, welcome back to the podcast.
Thank you. So excited to be here again.
We're going to be talking about sleep. Obviously, that's your forte, but could you do me a huge favor, though? It's been a little bit since you've been on the show, and Annie, it doesn't know you yet. So can you introduce yourself to the audience again and just kind of give us your background?
Sure. So I'm Teresa Power DeNike. I actually got my start in sleep medicine and dental sleep medicine, so I'm a little bit biased, if I'm being honest. I started working for a company that was manufacturing oral appliances, and I became pretty quickly obsessed, knowing that there are so many people who have sleep-related breathing disorders, and dentists have this incredible option to treat patients. A few years into that, I left and got my own clinical credential. I'm board certified in clinical sleep health I started a sleep coaching company to work directly with patients and sleepy clients who aren't yet patients, and just try to help connect them with dentists and physicians and psychologists to help with their sleep.
I love it. It's just interesting to me, like when someone gets so obsessed or so like into the weeds on a very specific topic, so like passionate about that. I feel like it's kind of unique. And so I love to hear that you are just like all about this, ready for us. Like we got lots to talk about. We're going to do a series, everyone. And this first one, we're going to be setting kind of the baseline and also talking about some kind of misconceptions that we might hear. Annie, did you have any questions that you want to talk about with Teresa before we get going?
No, I don't have any questions. My favorite quote that I've heard when we're talking about sleep is that sleep apnea is a medical condition with a dental solution. And you had brought up how dentists are just in such a unique spot to be talking about this. So I'm so excited we're having this conversation today.
Yeah.
I agree 100%. I mean, I could talk about sleep all day long, so let's get to it.
Yeah, I could too. So I love talking about this. So yeah, let's do it.
All right. I think with the jumping off point probably is like, let's start with the very basic introduction. What is sleep disordered breathing, obstructive sleep apnea, kind of all the terms that we kind of hear, but maybe aren't super familiar with if we're not really in the space.
Sure. Yeah. So I guess we'll start with the highest level overview. Sleep disordered breathing or sleep-related breathing disorders. It really encompasses a handful of conditions. So someone who has sleep disordered breathing, they have abnormal, if you will, respiratory patterns or even just insufficient ventilation during sleep. So just breathing problems that occur specifically during sleep. So as a dental professional, even you might start thinking about bruxism or, bruxism happens during sleep, maybe teeth grinding during the day, but bruxism was really a sleep thing. Sleep apnea, of course. We can talk a little bit about upper airway resistance syndrome. And none of these are just anatomy issues. They're also neurological and multifactorial in general, but there's nothing wrong necessarily with that person's lungs or their airway. So it's not just a breathing issue. It's also a sleep issue. So OSA or obstructive sleep apnea is by far the most common. It's the most commonly talked about. It's the most commonly, everybody knows someone who has it. I can very confidently say that every one of us three right here knows somebody who has it. I'm going to say that everybody listening knows somebody who has it, even if that person hasn't been diagnosed yet. And OSA is going to be the one that dentists can treat, I don't want to say easily, but fairly easily, especially compared to the other sleep conditions that do require more medical help.
And so I know when it comes to when you were talking about sleep disordered breathing and obstructive sleep apnea, and can you talk a little bit about sleep disordered breathing and the different manifestations that can fall within that spectrum? Because I think even something as simple as mouth breathing can be a huge problem and can progress into something else. And so I'm more so thinking about what we're looking at as far as dental professionals go and bruxism, and we see a lot of mouth breathers. And so I just wanted you to touch on that a little bit.
Yeah, that is such a good question because it's kind of like a fine line between what is the disorder and what is the sign or the symptom. A lot of times we'll see mouth breathers, people with bruxism who actually also have sleep apnea, for example. Sometimes it starts off as that and it worsens, or, vice versa, really. As I guess most people know, or it sounds like that mouth breathing isn't really ideal for any human. Nasal breathing is by far the healthiest way to breathe. Of course, we know that it's not really possible for all people. Maybe it's, a deviated septum or some other kind of condition. But ideally, everybody would be nasal breathing as much as possible. And we always really think about this during the day. I tell people to start thinking about it when they're just sitting and working or when they're working out, but it goes into sleep. And sometimes, I'll get the people in my DMs or trolling me saying, well, that doesn't make any sense because when you're asleep, you can't control your breathing and you can control if your mouth is open or your tongue is open, but your tongue is falling back in the back of your throat. But if we practice healthy habits during the day, then that can help with sleep. And it's also, again, like a sign or a symptom that you might be looking at in the dental practice. You might already be thinking about it. Maybe you're documenting it, but maybe you didn't know they could also be a sign of sleep apnea. just like snoring or teeth grinding. Again, you guys are going to see this. You're in there. The pulmonologist isn't going to notice that they have short crowns from grinding, but a dentist or, a hygienist will notice that.
For sure. I could talk about this all day, and I'm so excited we're talking about this because I get really, really stoked talking about sleep. And I do talk a lot about sleep with my patients, and I work in education, so I try to get students familiar with what they're looking at. So I don't know how much if you can speak into this, but as far as like the clinical signs we are looking for as dental professionals.
Definitely. Some of them seem fairly obvious once you learn just even a little bit more about sleep or sleep apnea. For example, if somebody just has a large tongue, that's soft tissue in their mouth that takes away from space of the airway. So potentially if they have a large tongue, especially during REM sleep, which is when all of our muscles are relaxed, they're basically paralyzed. That includes the muscles of the airway, that includes the tongue. So it naturally follows that if you have a larger tongue, that might block your airway or fall in the back of your throat and block your airway. If we're talking about your tongue, we're also going to think about scalloping and marks on your tongue, which again, you guys are going to notice.
Yep.
As CO2 builds up when we're having apneic events or when our airway is blocked, we have that need for breath, and that sometimes, in some people, triggers movement in their tongue or movement in their jaw, which might also manifest as bruxism. It's sort of a insufficient self-preservation because we're trying to open our mouth, trying to open our airway and get more air. So sometimes you'll see those markings on the tongue. And I feel like I already mentioned it a few times, but if you haven't picked up on it, people who use like Brooks guards, a lot of them actually do have sleep apnea as well. And maybe not everybody, of course, but it's sometimes such a strong sign that maybe they just don't know that they need a sleep test and they really should be getting an oral appliance instead of just being a mouth guard.
And so with that, I think a challenge that maybe dental professionals may face is that getting patients comfortable with us having these conversations in the dental setting. And so what is the role of the dental professional in identifying these? Because like I said, some patients will be like, well, you're working on oral health. Like, like, why are you talking to me about this? And how can we like craft those conversations? And what is our responsibility?
That's such a good question because it is like so obvious, and so many people will be like, yeah, you're right. Like, I came for a cleaning. Like, why are you asking me if I snore? I think the easiest way to start introducing it is just like add a few questions on your intake form, sort of plant the seed. Maybe don't jump into it all at once, even though, again, as you know, once you start learning about sleep, it's like you see it in everybody.
Oh, yeah. You can't unsee it.
You can't. But you're right. Patients are kind of like, what? I have no idea why you're asking.
Stay in your lane. Yeah.
Yeah. So, add a few questions to your intake form. Maybe you're on social media or you send some email blasts. But I mean, again, I'm a little bit biased here, but even as of 2015, which was many years ago at this point.
Almost a decade ago, yeah.
Almost a decade. The ADA had a policy that very clearly says that dentists and dental professionals should be screening for sleep apnea and sleep-related breathing disorders. Now, I know that a lot of work goes into people who really focus on sleep, and so maybe that's not your thing. Maybe you don't want to get into oral appliance therapy. I totally respect that, but knowing that there's such a huge need and all you have to do is screen that patient, I think it's really, really important. Just the way you screen for oral cancer, for example. I don't know how many dentists or if any dentist treats oral cancer. That's not my specialty, but I know that like everybody screens for it, right? So
that's a good point. Yep.
It's really, really important to screen for sleep apnea as well.
Yeah.
It's interesting for oral cancer. The onus is a little bit on the hygienist. I mean, I feel like at least we try and make sure it's within our scope of,
absolutely,
hey, hygienist, do this. And then the doctors really rely on us to do like that preliminary screening. I don't know how many dentists actually really do a thorough head and neck exam, oral cancer screening, et cetera, because they just don't have a lot of that time. For screening for sleep issues, are you also saying, though, that should be within the realm of the dental hygienist, that's something that we should be kind of trying to own as much as possible as well?
I think so. And there aren't really clear like regulations or, defined roles there, but I think it depends on how much you and your practice are getting into sleep. So if you want to be a sleep dentist, if you want to be a sleep-focused hygienist, airway-focused hygienist, I believe that that's really like a whole specific role. And I feel like we'll get into that more. You want to do the screening, you want to do the education, you're going to do the scheduling, the finances, who knows. I think at the very bare minimum, the easiest way in is to use, a clinically validated questionnaire. The Epworth Sleepiness Scale, for example, that's something that you're always going to need. And that's something that you can just add into your intake forms. And maybe you only know the basics. Maybe you just know the scoring and that's what you go over with your patients. Maybe you just look at their anatomy and that's what you go over with the patients. But I think that all of that is something that the hygienist can do. Again, you're already noticing so many of these signs. And if somebody's not comfortable with that, maybe the hygienist just looks at the anatomy and the dentist goes over the questionnaire. So it can really be done by anybody. Of course, I don't want to add to already overburdened hygienists. I know they're listening we have 6 million things to do. Please don't add this. But again, it's only a few extra questions and you're looking at it already.
And I think a lot of I think I can confidently say that hygienists we are looking to see how we can be more efficient in that time and incorporate these things. I mean, this is practicing with the highest level of care. And so if we want to start looking at a patient from a comprehensive standpoint and also understanding too that the oral health is being affected by all these other things too. So I think that's a really critical component to look at. And you had mentioned just putting it in the intake form. I think that's really valuable because it doesn't take very long to add that into a medical history form, or if you're seeing signs, I think it opens the floor to have that conversation with patients too.
Mm-hmm. Yeah, I think so. I mean, look, they're already filling out other forms and check boxes and everything. What's 30 more seconds of an additional screener?
Right. And I think it also goes to some patients may not be 100% receptive of talking about it, and that's okay. But there are going to be a handful that are really, really interested and are going to be yes, I experience all of those things. How can you help me? And so I think that is a really great, a space for dental professionals to get into.
But I mean, likewise, though, the dental professionals are always going to be on board. They're not going to be interested in having those conversations either, right? They're going to want to maybe kick it down the road, or they're going to do these things. I guess my question is, how do we get them excited? How do we get them interested? How do we help the dental professional, whether it's the dentist or the team member, feel that importance that these are the topics and conversations you should be having, even if you're not going into the deepest of conversations? But even if it's hey, I see this thing, refer out, right? Refer, go see someone else. How do you get someone excited about that kind of conversation?
I think treating some of the office is the easiest thing you can do. And it also helps you to feel that importance because, again, it is so different than general dentistry. But it's once you get that first patient, whether it's, your mom, your sister, the receptionist, whoever it is, once you see the difference and they tell you straight up, I am sleeping with my partner again, I'm not snoring, I have no more morning headaches. It could just be one person, but it really opens your eyes because sleep is so subjective. Mm-hmm. When they tell you how amazing they feel, and something really low pressure would be to treat someone in the office, because I guarantee, again, there is somebody in your office who has it or their bed partner has it. So it's not like you have to look very far to find that first patient.
It's interesting now that you mentioned this, sleeping in different rooms, your partners. I don't know, Annie, if you saw just yesterday, the day before, in one of the hygiene forums, the question was posed, and I'm sorry, we're getting way off track here, but I'm getting the story anyway. But the question was posed. She said, "Look, my I think they call it sleep divorced. I think so. She called it, my husband and I were sleep divorced. He's in another room right now. He's getting it taken care of. He's going to get all screenings and get tests and get whatever they end up doing for him. And I have the bed to myself, but I'm telling you, I'm having the best time of my life in the bed. No, not because he's not here, but once he gets fixed, how do I tell him I don't want him in the bed anymore? Because I have a room."
Oh my God, that's a great question though.
It was so funny, but I'm yeah, you got a good point there. I'm get a California king size bed, maybe? I don't know.
Yeah. It is a good point. People in sleep, we do have this love-hate relationship with sleep divorce. It's very catchy and people are always writing about it. And the goal a lot of times with oral appliance therapy, for example, is to get partners back in the same bed. But in the best case scenario, that partner is being treated. If you have different schedules or you're restless or you just need space, I love a good sleep divorce. If you're getting better sleep, I don't care where you're sleeping, as long as you're not sleep divorced because one person is snoring and you're ignoring it and you're just not listening. But otherwise, I don't know, it's kind of up to you.
I mean, I feel like we all have like family members who like, oh, all right, well, grandma and grandpa did that for forever. You know, like, that was so normal, blah, blah, blah.
Yeah.
And it's not, I mean, I guess if you grew up with your parents doing it a different way, then maybe that's different. But like, I think we all have relatives that have like lived that life.
And we've kind of normalized it, like you've said, which is, in my head, it's very concerning that we've normalized that a little bit. But it's also encouraging that just the advancements that we're making now. So I'm encouraged by that.
Can we circle back real quick? I think you said it, or maybe you were really leading to it, but like, okay, like we've discovered something. Just quickly touch on the referral process. Like there are, if we don't want to treat it ourselves or we're not capable of doing it, then there are people that we refer to. Was that what you were saying?
Yeah, absolutely. I mean, in theory, really any dental professional, any dentist can treat patients for oral appliance therapy. You know, if you're comfortable, if you're just doing a few, if you have patients who are super friendly, it's your cousin, whoever, you can do it because you're a dental professional, you're an expert in the oral space, which is where the oral appliance is going. But if you are not really comfortable even just like talking about the patient, you're not sure how to manage potential side effects, you can refer out to a sleep dentist. There are plenty of people who are diplomates and board certified. You can find them online. Just, again, the same way that you would refer out for endo or orthodontics. You know, people, as far as my experience anyways, people sometimes feel like really weird about that. They're like, oh, I don't want to send my patient to a sleep dentist because what if they don't come back? Or, you know, what if they take them as their dentist? And for the most part, if it's someone who's doing primarily sleep, they're not going to keep that patient anyway. And also, you know, again, hopefully you can trust your colleagues or at least have very open communication with them. If you're sending them just for sleep and they stay there for dentistry, I mean, that's kind of up to the patient anyway. But I'm hopefully, like, you set those expectations and you have that communication with them because, again, you refer out for other things as well.
Mm-hmm.
Are there, as far as like when it comes to referrals, and I know you had said like pretty much all dentists can treat patients with oral appliance therapy, which I believe we're going to talk about appliances a little bit later in a later episode, so I won't get too much into that. But as far as like, are there limitations as far as what a dentist can treat and like when referral is absolutely necessary as far as a patient's condition goes?
If they have very severe sleep apnea, CPAP or other treatments are always first-line therapy. But actually, this kind of will go into like our misconceptions.
Yes, yeah, that'd be great.
Oral appliance therapy used to only be for mild sleep apnea. Now it's for mild or moderate sleep apnea. And even if the patient has severe sleep apnea, if they have failed CPAP or they're just straight up refusing it, oral appliance therapy can still be recommended and it can still be covered by many insurances. So sure, of course, if they have this severe disease or if they also have, you know, lung disease or any other sort of like serious medical conditions, we don't want them to just do oral appliance therapy. But I mean, simply speaking, something is better than nothing. If they are not using anything else and they are struggling to breathe in their sleep every single night, then yeah, they can still use oral appliance therapy and benefit from it. And yeah, mild and moderate is a pretty wide range of people. So it's not as limiting as people might think.
This might be kind of a dumb question, but like, okay, so we have these oral appliances that, you know, are like fabricated in the offices or through labs or whatever. Is there a difference between the type of appliance for a mild case versus a moderate or severe case? Like, I'm trying to think of like, and this is a really bad example. And don't roast me in the comments on this one, but like, it's one of those things like, if you got a really strong bite, you want a little bit more of a more firm or whatever material. Like, so I guess like what I'm trying to think is like, you know, the type of material that we're going to use to be a little bit more robust. It's going to be something that can withstand the pressures more. So if they had, you know, more of a moderate or severe case, is there like a different type of appliance or a different degree or a different, like, do they change it or is it literally just the same appliance for like simpler cases?
I think it's kind of a yes and no answer to that. So yes and no, because there are different kinds of appliances based on, you know, the needs of the patient. There are devices that are stronger and more durable, but there's, you know, devices that are made typically in a dental lab or something called an EMA, or like, I don't want to say flimsy, but they're not as strong, but that's not necessarily going to make a difference on the treatment of their sleep apnea. And anybody who's getting treated specifically for sleep apnea should be getting a medical grade device in the dental office, a medical grade device. And there are also different kinds of those, but they're not necessarily like stronger or for different severity levels. And those kinds of devices are all adjustable anyway. And so even if you get one of those, it can be adjusted, to give you more or less protrusion, is what they would say, to help open that airway, depending on your severity.
And so you're referring more to like a mandibular advancement appliance, correct?
Yes.
Yeah, and that's more like as far as like adjusted depending on the patient's condition. And that can be adjusted like over time too, because the patient's condition would obviously could change over time.
Mm-hmm. Yeah. Okay. And that's a really good point too, because, maybe a patient has a snore guard or something a little bit less than, I guess I would say. But maybe then they get an oral appliance and it's totally different. And maybe they lose weight, or maybe, some of these can happen. They keep these devices for years. Their bodies change. So they can be adjusted, and they should be adjusted.
I was going to touch on misconceptions as far as over-the-counter like snore guards goes, but I don't know if we want to save that for the latter part when we start talking about appliances and things, because that's also like a big topic that we could get into. Because I feel like in dental offices we identify bruxism quite a bit. And you talked about bruxism, and night guards are usually the option, which I personally have a lot of beef with night guards. But I think it more so is just like, you had mentioned it too earlier, but getting to the foundation and understanding the foundation of the patient's condition. And so just giving a night guard could be an option for someone, but I don't feel like it's necessarily addressing the root cause.
Yeah. And if anything, sometimes it can actually make it worse, because some of those night guards are going to be holding the patient's jaw exactly where they put the device in. And that could be worsening apneic events, or really kind of preventing them from getting more air when they need it during those events.
Is there a misconception around, like, from the provider standpoint, from like the dental professional standpoint, is there a misconception about this information is very hard to learn? Because it does kind of seem like it's, because we're not really taught this in school, that I have to take a 2-year-long course to figure this out. I feel like there's a misconception there with like the learning curve, like it's hard.
Yeah. And I think, that definitely prevents a lot of people from doing it. It is very different from general dentistry. Again, a lot of sleep dentistry is more about just talking to the patient. Physically, or like workload is pretty minimal, as you probably know, Annie. It's scanning and screening and getting this device and like telling the patient how to use it. It's not a lot of work. You don't need like a lot of equipment at all. So that's not the hard part. It's really depending on how much you want to get into the weeds of sleep, because it's a whole, medical field. And so that can scare people sometimes. But, if you don't want to do that, maybe when you're a hygienist, or maybe you get a new, quote unquote sleep coordinator, maybe they focus just on that. So at the very basics, it's not very difficult. It's not physically difficult. It's not difficult to learn. You guys went to a lot of school to do what you do. It's one more thing, but it's really in the nuances, like how much do you want to know about this medical field?
Well, and I think you brought up such a great point. We're going to talk about this, and as we start to wrap this up, we're going to talk about it in our next episode. But as far as how to integrate this into your practice, and how to integrate it as far as how to welcome, or how to use sleep coordinators, I think that will be the thing we're going to talk about next week. Teresa, thanks so much for being here today. Is there anything else that you can touch on, or any other tokens that you want to share with our audience as far as topics that we talked about today?
Not really. Just start screening. Just start
screening. Yeah, start screening.
If you have any other questions, if you want to reach out to me, the easiest place to find me is on Instagram at SleepBetterNYC. And I also cover some of the screening and like super quick things that patients and physicians and dentists can like ask each other just to get started and like get your feet wet.
Okay. Well, thanks so much for being here. We really appreciate it. And we look forward to having you on for our next episode.
Thank you. See you soon.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.